Manager Martin. Okay, great. And then number 2, receive and discuss an update on the Black Men's Health Clinic. Dr. Nicholas Yagoda, Chief Medical Officer of the Community Care, will be presenting, and there will be no motion needed on this item.
Good afternoon, everyone. Thank you for having me. My name's Nick Yagoda. I'm the Chief Medical Officer of Community Care, as stated. We're grateful to be welcomed to this meeting to discuss our progress on the Black Men's Health Clinic. If we go to the next slide. This work falls squarely in line with our strategic priorities, which mirror in many ways those of Central Health. It's surrounded by it's based on 5 basic pillars, the center being health equity, supported by quality, community, growth and engagement, workforce well-being, and resourcefulness. This particular initiative applies most directly to those pillars of equity, quality, and community itself. Next slide, please. This is a bit of the milestone. It's an updated version of what you all saw last summer. But over the course of the last year and a half, we've progressed from what was an idea to an actual brick-and-mortar clinic, seeing patients at a greater and greater clip each week. So starting in the second quarter of 2022, we identified the location, opening up in March. Our board of directors at Community Care recommended addition of this clinic to our scope of practice as a federally qualified health center. In the fourth quarter of that year, this board of managers approved funding to support the outreach for this community, which represents a cornerstone of the work that it undertakes, and I'll go into further detail on that in later slides. In the first quarter of 2023, we got approval to add this to scope. We've hired in the next quarter our first provider dedicated to this clinic 1 day a week, and outreach events began. In the third quarter of 2023, we expanded access to care through a modified scheduling template, which saw a progressive increase in access to care, which I'll demonstrate on a future slide. And then in the fourth quarter, this board of managers graciously allocated additional funding to support personnel, outreach, and patient navigation. And in the first quarter of this fiscal year, we transitioned from 1 to 3 days per week and added some innovative recruitment practices within our HR department to identify multiple provider candidates that will anchor a full-time operation going forward. Next slide, please. So here are a couple of key highlights from Central Health funded activities. First is the expanded operation, which I alluded to. We've been able to yield more visits for our focus population. We've increased our scope of practice to expand into the mental health range. This is complementary to what is being developed in collaboration with Integral Care. Our outreach impact has broadened to actually now enroll eligible folks in MAP, as well as participating in the coordinated assessment for housing. The funding has helped to diversify sustainability by enabling the receipt of external grants secured from St. David's Foundation, Austin Public Health, ECHO, Hogg Foundation, among others. And the BMHC staff has been able to staff more than 250 outreach events. A number of them are listed, but this is just a small list of what is a fairly exhaustive line of events. Next slide, please. Clinical progress. So in the last 6 months, we have continued to increase, reaching 379 completed visits. That is much lower, I will note, than what we expect in general primary care clinics, but this is very different. And I'll go into some of those details of why this is so different and why caution in productivity is urged at the outset as we focus on building trust with a community that has been marginalized and disenfranchised for so many years. A handful of female patients have been accessing the clinic anecdotally. These are spouses and family members, partners of patients themselves. We have scripting to redirect patients to appropriate medical homes, but as is consistent with all of our clinics, we don't turn away any patients. Our primary diagnoses, which you'll see listed on the right, track with the general health profiles of men of color in the United States, leading with hypertension, diabetes, and chronic pain, all conditions that are disproportionately seen in marginalized populations. Next slide, please. Our no-show rate is improving. Our efficiency of service is improving, but it still remains high. I'll bring your attention to the yellow line. You'll see at the outset of of the last 6 months, we had a no-show rate up almost as high as 50%. That has steadily decreased down to 31% because of innovative scheduling approaches and some very thoughtful approaches from our operations team. You'll see that the green bars represent completed visits. Those have steadily increased again because of how we've modified templates and access. But in particular, as noted with that dark blue arrow, we transitioned from 1 to 3 days a week of operation starting in the beginning of November. We expect those numbers to continue to climb. Next slide, please. The majority of our patients are male and are from east of I-35. So on the left-hand side are breakout by gender. Green represents patients who identify as male. Blue are patients who identify as female. You'll see that the vast majority are hitting our focus group. And then, unsurprisingly, we are pulling patients from not only along the I-35 corridor, where you see the greatest density, but also along the eastern Travis County, that crescent being a target both of our and Central Health's equity outreach. Next slide, please. The majority, in terms of insurance status, the majority of the BMHC patients are uninsured. I'll draw your attention to the light blue and orange, which represent MAP and MAP Basic. In that stacked bar graph, you'll see those progressively increase. Of note, the self-pay comes in second or third, depending on the month. We believe there is further work that we can do to tease those out. We suspect that a number of those who are on self-pay may actually qualify for MAP or MAP Basic. Next slide, please. In terms of race and ethnicity, the majority of patients are identify as Black, non-Hispanic, Latinx. That is the orange graph that is most tall on the left-hand side. But we do have a sizable portion of Hispanic, Latinx population as well. Despite the name of the clinic referencing this important key focus group, all men of color face health disparities and thus are welcome at this clinic. But we are devoted to creating a home particularly towards the particular focus group of Black men. Next slide, please. So a bit about the care model. It is threefold. The first part is establishing the brick-and-mortar clinic. This is to build an inclusive, culturally aligned environment housing a full-scope, patient-centered medical home. At the outset, we considered whether we wanted a more mobile operation to focus on outreach efforts as well. We decided against that. Instead, to build a home that felt like it was a destination that our focus population would be able to feel welcome in and feel like they had a home in. So we have undertaken some work to establish that brick and mortar clinic, which is incidentally in a location that was not designed to house a clinic, but we're trying to retrofit in the most efficient manner to have it reach Joint Commission standards. The second arm of the model is a robust outreach and navigation operation. Probably most important during the early years of this work is building trust, a knowledge base, and partnership to deliver most effectively on the promise of equitable health outcomes. This is a community that has been burned for generations, and it is not going to be something that we can simply flip a switch and expect us to be able to deliver the quality of care we aspire to. So we are patient in our approach, and we are focused on that outreach most particularly, which is a rather novel approach to how we do traditional primary care, even in an FQHC setting. The last bit is that this is a team-based approach. We recognize that certainly the physician or advanced practice provider and that core teamlet remain at the center, but we wrap them around with clinical pharmacy, behavioral health, nutrition, case management, community health workers, and the like, because of the extent of the social non-medical drivers of health. We need to ensure that these patients feel adequately wrapped in their full breadth of need. Next slide, please. So objectives for this coming year. First is provider recruitment, ideally a Black male physician or advanced practice provider. We have some promising candidates. We've even made an offer a few weeks back. We're waiting on that negotiation. Secondly is establishing facilities that meet Joint Commission standards. This is a laborious process, but one that we are committed to establishing this on par with all of the excellence that we see at our other clinics. Thirdly is expansion of access. As noted in November, we moved from 1 to 3 days per week. This is an 8 to 5 operation, which may not be ideal for the focus population, or at least certain segments of that. As we build engagement with the community, further expansion of days and hours is contemplated. Outreach, as noted, remains the cornerstone, building trust and awareness. We have focused demographics and geography. Word of mouth has been activated and is bearing fruit. Much of that increase in utilization is related to word of mouth. Even some of our recruitment is related to word of mouth. So the cultural component, the connection between humans is very important to underlying success of this clinic. Engagement and navigation, we are building on the social justice principles and the social medicine principles of accompaniment, where the patients do lead through the process of achieving their health goals, and we are accompanying them through what is a very complex system that includes structural violence, bias, and various barriers that are more than one individual may be able to handle on their own. We are there as advocates as well as caretakers. And lastly, patient experience. The patient voice needs to lead the development of this particular clinic. We are building out micro-surveys so that we can, on a moment-to-moment basis, be informed by the community's needs. This is intended to be a community-informed healthcare practice. So with that, that wraps up our summary of the last 6 months of development of the Black Men's Health Clinic. I'd be happy to entertain any questions you'll have.
Yes, Manager Valdez.
Sir, I'm very hopeful and very happy with the successes that you've had. I know how difficult it is getting a startup clinic going, especially in a historically marginalized community. I was wondering whether or not maybe at the end of this year, whether or not y'all would be offering suggestions to Central Health if there are any tweaks that need to occur and how to better reach out to historically excluded populations, specifically the Black male. And maybe, you know, since we support each other 1,000%, that would be, this would be maybe a learning experience. And is anybody doing a study out there that they can do a paper on and put it out for publishing? Thank you.
I very much appreciate those comments. Certainly, we are invested in this together, and any learnings we glean from this process would want to be broadcast so that other advocates doing similar work would be able to leverage the same knowledge base that we gain. I would, from a research and best practice perspective, there is a dearth of information out there of successful programs. There have been certain highlights that have been rather short-lived, in my opinion. Our intent is to be able to establish a long game and one that can be distributed not only to other FQHCs, but even more broadly to entities beyond just the direct primary care practice.
The reason I was looking at that is because this is a generational issue, and we want to see generational impacts.
Yeah.
Thank you.
Yeah.
Manager Barton.
Thank you for the work you're doing. I have a question about the diversion of patients. You know, primary care delivered in the context of spouses and children has been proven over and over to be important.
Yeah.
A disease doesn't just affect the man, it affects the spouse or significant other. and the children, and why not just continue to, I think it's great to continue to aggressively market it to the black men, but to incorporate, allow the families to be seen, and what the negative impact you would see in doing that versus a positive impact of delivering sort of complete family care to some extent.
So as a family physician, I greatly appreciate your perspective. First, all doors have to be open doors. We've had the same questions you did. And the position we've taken is at least a pilot position, and it is one that is largely driven by the community's feedback. We have already received feedback that among the focus population, when others who are not of that particular demographic are seen as part of the clinic, it starts to erode perhaps some of the original intent. Whether that is enduring or if that is just a culture we need to build of broader inclusivity while maintaining a focus on a particular group, I think that stands to be learned. But this is based on feedback we've been getting from patients themselves that there was some hesitancy to engage at the level that they might otherwise engage when seeing a exam room full of patients that look different than they do.
Right, and I'm still saying market it aggressively to the black men who are incredibly underserved.
Yeah.
But if that instance where a spouse comes in or whatever, to sort of welcome that person in the context of the delivery of care, as you well know, as a family doctor. So I'm just saying that I would appreciate if that context was kept open to aggressively market to the black men,
Sure.
which is needed
Sure.
dramatically, but then also to have an open point of view, as you are, I think, about sort of listening to what the community wants.
Mm-hmm.
But as you and I both know, care is better delivered in the full context.
Yeah,
So.
fully understood. And as stated before, anyone who walks in the door asking for care gets the care delivered on site. And for more of a long-term planning, we have been looking to whether there might be better fits from a location standpoint, but it is not a cut and dry issue, and we continue to keep that alive. Yeah, appreciate that comment.
Yes, Manager Jones.
Thank you very much for the work you've done. I know you've had 6 months and you've done quite a lot in 6 months, so I want to compliment you all on that.
I appreciate that. Thank you.
I concur with my colleague, Manager Martin, with regards to the inclusivity-ness of it. I also understand that when you're building something, you start with your roots and then build upon that. So my understanding is that you're going to continue to focus on the black male, but also incorporate those in as well.
Yes.
As part of that question, though, is there a sliding fee scale for those that fall outside of the purview of our MAP program?
Oh, without question. Yeah.
And the reason I ask that is because if you look at the data in terms of public health outside of those who are just 200% of poverty, there are a large number of individuals who could benefit, not necessarily from the clinical aspect, but maybe from some of the social and counseling and other kinds of services that would be unique for black men that are not being received in the general population as a whole. So I don't know if you all have considered maybe down the road, obviously not now as you're building out, but the possibility of incorporating special focus areas for people who may not qualify based upon their income, but who could certainly qualify for some of the other services and who could pay for it through private insurance or their own way. So are you all considering that as well, I guess?
I would say that is beyond what the immediate considerations are, but certainly in the long run, this should be informed by the demands of the community. And we know that we have a relationship with the community that we believe allows us to establish a level of trust and buy-in that gains them access to services, even if, regardless of where they fall in that spectrum of income and insurance status, that is of substantial value to the public health and population health. So I would say it would be something that we would certainly be eager to explore further on down the road once we get these initial objectives obtained.
And I certainly understand that point. I would encourage you maybe to look at some of your other partners who are doing things out in the community that might be able to provide that on an ongoing basis as you develop or roll it out as well. So,
I will say it's important to give a great deal of credit and respect to the work that the leadership of Black Men's Health Clinic, Mr. Larry Wallace Sr. and Dr. Larry Wallace Jr. have led in building very, very important partnerships that really build a comprehensive, integrated, and complementary suite of resources beyond just the services that community care offers. So I think as this relationship matures, as the leadership gels on a vision beyond just the short term during this initial pilot phase, or it's not a pilot, but during this initial rollout phase, we should see a lot of those aspirations come to fruition.
and finally, I say that because I have seen, and to the credit of the leadership of the clinic, a lot of visibility in the community about the clinic, and they are to be commended for the work that's been done.